Welcome to this webinar organized by EURO-NMD in collaboration with the European Reference Networks for Rare Neurological Disorders and the European Academy of Neurology. Today we have the privilege of having with us Philip van Damme to talk about the guideline on the management of ALS. Philip is a professor of neurology at the University Hospitals in Leuven in Belgium, and is leading the Neuromuscular Reference Center there. He trained there a few years ago and did a PhD during his training on disease mechanisms of amyotrophic lateral sclerosis. And that was always his field of interest. He was a visiting fellow in neuromuscular at the Massachusetts General Hospital in Boston, and also at the Day Laboratory for Neuromuscular Research in Harvard Medical School in Boston. Since 2009, he's a neuromuscular expert and specialist, and has been leading more recently the ALS program, and that involves the diagnosis, treatment, and multidisciplinary care for patients with those diseases. He has an active interest in clinical research with work done on genetic biomarkers, neuroimaging, and a focus on genetic modifiers of ALS and disease pathways in pluripotent stem cell models derived from ALS patients. Is currently a principal investigator in the Laboratory of Neurobiology that is part of the University of Leuven, and he has more than 200 publications around ALS and similar neuromuscular conditions. Thank you, Philip, for agreeing to give us this webinar on the guideline on the management of ALS, and the floor is yours.
Thank you very much, Antonio, for the kind introduction. So I will talk about the guideline that is recently published on the management of ALS, and I give this presentation on behalf of all guideline panel members. These are my disclosures. The ALS treatment landscape is rapidly changing, and therefore it was clear that we were in need of an update of the guideline on the management of ALS that dated back to 2012, and that was made at the time under the leadership of Peter Anderson. And so the new guideline, it was quite a lengthy process to make the new guideline, and the paper was published in the European Journal of Neurology earlier this year. So what I would like to do first is to give a little bit of background about the process of the guideline production before we delve into some of the actual recommendations. So the guideline was originally commissioned by the European Academy of Neurology, the EAN, but was made in close collaboration with the EURO-NMD, but also our European network of ALS centers called ENCALS, and also the European Patient Organization called EUPALS. We had the privilege to be collaborating with Cochrane Response for support to make the guideline. The guideline panel consisted of key opinion leaders, ALS experts, neurologists from 13 European countries. You can see on the map the names and the countries that were represented. We had good representations across Europe. Maybe Eastern Europe was not very good represented. Then we had 2 reviewers from Cochrane Response and a patient representative from EUPALS. As requested by EAN, we followed GRADE methodology, which stands for Grading of Recommendations, Assessment, Development, and Evaluation, which is a regulated process, and the aim is to be very explicit and transparent about how the recommendations are made. The idea is that if you ask another panel to make the guideline, that they come up with similar recommendations. It are evidence-based recommendations, and we can use this evidence to make strong or weak recommendations for or against certain interventions. In the past, many guidelines rather used class 1 evidence, level A type recommendations, and oftentimes there was a quite strong correlation, almost a one-to-one relation between having strong evidence, for instance, a good quality randomized controlled trial for a certain intervention, and giving a strong recommendation in favor of this intervention. But in GRADE, the process is a bit more complicated and well described. So the first step is that you have to decide what you want to make recommendations on. So you have to formulate research questions using the PICO format. PICO stands for population, intervention, comparator, and outcome. And this has to be pre-specified. Then literature searches can be done, and meta-analyses of different studies and outcomes across the studies can be made. And then you end up with an evidence table, summary of findings, where the evidence can be rated. And in principle, if you have good quality randomized controlled trials, you have a very high quality of evidence. This quality can be downgraded, for instance, if there is risk of bias, inconsistency, indirectness, of imprecision. And on the other hand, if you have good observational studies, you can also use this evidence. Typically, you start from a lower level of quality of evidence, but this can be then upgraded if you have, for instance, a very large effect of the intervention, or when there is a clear dose response, or when there are confounders that work against the therapy and yet you see the effect. When all the evidence is graded, this is discussed in the panel, and then the panel has to formulate recommendations for or against, and that can be strong or weak. And this is not just based on the quality of the evidence. Of course, the quality of the evidence is very important, but also the balance between benefits and harms. For instance, if you have a therapy with very strong evidence in favor of the therapy, but it also has a lot of side effects, this may influence the strength of your recommendation. Also, values and preferences may be important. If you have a therapy for a symptom that is maybe not bothersome to patients, this may influence the strength of the recommendation and also the cost of the therapy. And so in the end, recommendations are formulated strong or weak for or against a certain intervention. The method we used to process, the first step was a guideline mapping effort, because GRADE also allows to look at other guidelines that used GRADE methodology and to adapt recommendations if they had similar research questions and the evidence has not changed in the meantime. There is only one ALS guideline that used the GRADE methodology, and that's the UK NICE guideline. We were able to adapt 8 recommendations from this guideline. All the other recommendations were de novo, based on new systematic reviews or updates of existing systematic reviews. Then the evidence to decision framework was followed. We had multiple consensus meetings online and in person, and the whole process was supported by Cochrane response. This is an overview of all the topics we covered in the guideline, and roughly you can discriminate 3 large domains. The first is disease-modifying therapies, where we looked at the effectiveness of treatments like riluzole, but also the more recently approved therapy tofersen. A second category are more topics related to multidisciplinary care, communication problems, end-of-life care, what to do in case of malnutrition and respiratory symptoms and muscle weakness. So all related to the care of patients. And then a third category deals with a long list of problems and often disabling symptoms that can occur in patients with ALS. And for which we often can offer treatments, such as muscle cramps, spasticity, musculoskeletal pain, sialorrhea, emotional debility, fatigue, constipation, hoarse voice and laryngeal spasms, insomnia, anxiety, depression, and also the primary prevention of DVT. For the purpose of the paper, we divided all these topics into 9 chapters. Chapter 1 is about disease-modifying therapies. Chapter 2 about service delivery, the organization of multidisciplinary team care, management of communication, management of nutrition. Then Chapter 5, management of respiratory symptoms. Chapter 6 is a bit a grouping of all kinds of other symptoms. And then we have Chapter 7, psychological and emotional support. Chapter 8, prevention of deep vein thrombosis and end-of-life care. We will not have time to go into detail about all the recommendations, but we will cover some of them. But before we do so, it's important to realize that patients with ALS not only have a variable motor presentation of the disease, there can be, to a variable extent, upper and lower motor neuron involvement. The site of onset can be variable. Also, the speed with which the motor symptoms progress can be variable. But in addition, 50% of patients also have extramotor problems related to degeneration in the frontal and anterior temporal lobes, mostly reminiscent of behavioral variant frontal temporal dementia, but sometimes also non-fluent variant and semantic variant of primary progressive aphasia can occur. In about 10% of patients, a concomitant diagnosis of FTD can be made, and about 40% of patients have milder cognitive or behavioral symptoms. And it's clear that this can influence the management of patients, but because there's not a lot of evidence how it should influence the management and how we should treat those patients differently compared to patients without cognitive or behavioral symptoms, we decided not to discriminate between patients with and without frontotemporal dementia, but just made a kind of general disclaimer saying that it's important to realize that it can influence the management. It's important to look for it and to assess if patients are able to make decisions, give consent, and accept and cope with the treatment you propose. Another thing that is important to realize is that the available evidence per research question is variable. As you can see here in table 1, you have all the interventions. And here in this column, you see the randomized controlled trials that cover the topic. For disease-modifying therapies, we have randomized controlled trials. But for many of the topics, there are no randomized controlled studies, such as service delivery, which is understandable. It's difficult to randomize between having multidisciplinary care or not. Management of communication, there's no RCTs. The management of weak cuff or thick mucus, there's also no RCTs. For muscle weakness, sialorrhea, we have some studies. The effectiveness of interventions for constipation, hoarse voice, and so on. Also for anxiety and depression, there's no specific studies that RCTs that cover the topic. Primary prevention of DVT, and also how to organize the end-of-life care. So it's important to know that for 13 topics, no RCTs or high-quality RCTs are available. But yet, GRADE allows to make recommendations in case of empty reviews if you don't find RCTs. And it's not just good clinical practice points. Of course, it's not possible to make a strong recommendation in favor of an intervention if you don't have good quality evidence. But that doesn't mean that you cannot make recommendations. And also, it's in particular in these areas that we can make recommendations for further research. More studies are needed. A concept that is sometimes used is evidence versus eminence. For many of these topics, there may be a lot of expertise, key opinion leader experience with certain treatments, and we can use these treatments even though we don't have high quality RCTs. So let's now have a look at the different chapters. First, the disease modifying therapies. We started, of course, by looking at the effectiveness of riluzole, the drug we have since the 90s. The original study showed an effect on survival with a hazard ratio of 4.66. This trial was published in 94, and almost immediately a confirmatory phase 3 trial was run with 3 doses. The typical dose is 100 milligram, two times 50 milligram per day, and the hazard ratio was nicely replicated. So the therapy seems to be very robust, although the size of the prolongation of life is not so big. There is also more recent unpublished evidence. These are the results from the Empower trial from Biogen. The therapy that was under study, dexpramipexole, did not influence survival, but patients on and off riluzole were allowed in the trial. And here you see the survival curves for patients without and patients with riluzole. And again, a hazard ratio of about 0.7 was identified. Another study is from Precision ALS, which is a project within TRICALS, in which patients across Europe that are on and off riluzole were compared in terms of their survival, and there again a hazard ratio of about 0.7 was observed. So all these studies confirm that riluzole is doing something. It is prolonging survival of ALS patients. What we don't really know is what is the optimal timing for riluzole treatment. There are some studies, as here indicated on the left, that starting riluzole early on is better. If you start riluzole at 6 months, it seems to be working better than when you start it only after 30 months of disease progression. But on the other hand, there's also evidence that it is still working late in the disease. This graph is a reanalysis of the original Lancet paper from 96. And you can see this is a Kaplan-Meier curve for the progression from a certain disease stage to the next. Early on, from stage 2 to stage 3, or progression from 2 to stage 3, you see there is not much difference. But here in the upper panel, you see the proportion of patients remaining in stage 4, and there you clearly see the benefit of riluzole, so suggesting that it can also have an action later in the disease progression. So finally, we came up with the recommendation to offer lifelong riluzole to all people with ALS at diagnosis. So there's no reason to postpone the initiation of riluzole, and also no reason to stop it, because it can still be active later in the disease. Riluzole has side effects in about 10% of patients, mostly nausea and fatigue. And if that is the case, you can reduce the dose, or if it's really not tolerated, consider stopping riluzole. We now have different formulations, so also for patients with swallowing problems, there are solutions, even if they don't have a gastrostomy. The second disease-modifying treatment, tofersen, is an antisense oligonucleotide therapy that is delivered intrathecally for patients with SOD1 ALS. This is really a game changer for the field. It's the first molecular treatment with a large effect. Here you see the results of the phase 3 study published in the New England in 2022. The therapy was first shown to have clear target engagement. The ASO results in a reduction of SOD1 protein levels in CSF. The reduction is about 40%, and a very dramatic decrease in a biomarker, neurofilament L, which is a marker of neuronal and axonal injury, is observed. the reduction is about 50%. But the clinical endpoints at the primary endpoint at 6 months didn't reach statistical significance. This is the result of the ALS functional rating scale revised, where there is 1 point difference in favor of the treatment, but it's not significant at all. The same is true for muscle strength. At 6 months, there is no effect. However, the long-term effects of the study clearly show a benefit. After 6 months, all participants received the therapy, and you can see that patients, the disease progression is halted. Patients are doing it better when they receive tofersen from the beginning, that they do it better than patients that only received it after 6 months. And for muscle strength, there is a similar observation. The disease seems to plateau, even improve in some patients, and these patients are doing better than the ones that only started tofersen at a later date. So there's 2 important conclusions from this trial. First, that the treatment is effective. But the second observation, which was an eye-opener for the field, is that even when you have a therapy that is having a strong effect on the neurodegenerative process, it takes time, more than 6 months, to see the clinical response. It's also important to mention that tofersen has some serious side effects. SAEs were reported in 7% of patients in the trials, and the 2 most feared are myelitis, which can be a subacute worsening of weakness in the limbs, lower limbs, with sensory problems. And you can see hyperintensive signals in the spinal cord. Mostly this is responsive to stopping the therapy and steroid treatment. And a second serious side effect can be increased intracranial pressure with visual problems, headache, and papilledema, which can respond to taking extra fluid every month and also acetazolamide. The final recommendation we made for tofersen is to offer it to patients with progressive ALS caused by pathogenic mutations in the superoxides mutase 1 gene as a first-line therapy. But it's very important to discuss upfront that the treatment may be associated with serious adverse events. It's also important to discuss that in patients with a slow disease progression, the balance between benefits and harms may be different than in patients with a fast disease progression, and also the treatment burden is obvious as it is administered intrathecally every month. But it is a real game changer for the field. More and more patients are being treated now across Europe, and also the first results from real world evidence are very supportive of the effect of the treatment. The second chapter is service delivery. Multidisciplinary care remains the cornerstone of the management of ALS. For most patients, we can not cure the disease. We have to manage the disease progression and all the symptoms and problems that come along. It's a whole team we need, and it has not been shown in RCTs, but there are multiple observational studies that you do actually good for the patients. This is an example of study we conducted in our sites. You see the survival curve of patients that were followed in our sites, or patients that were just seen once for a second opinion and not followed in a specialized ALS center. And in a Cox proportional model, follow-up in an expert center was an independent predictor of survival. So confirming that somehow we do improve the survival of patients, although it is not clear which specific intervention or which combination of interventions is mediating this effect. It's also evident if you look over time that improved care is improving outcome. If you look at the survival of the placebo group in RCTs, this is progressively increasing over the years. It's now more than 90. It's becoming problematic to use survival as an endpoint in a short trial because the number of events is becoming too small. And this is also what we and others have reported, that if you compare the survival of cohorts of patients long time ago versus more recent, that the more recent cohorts do better, most likely due to improved multidisciplinary care. There are some recommendations about the composition of the team. It's a whole team you need. There's also some recommendations about how you can organize the care, that you should see them on a regular basis, tailored to the disease progression. It's also preferable to have the possibility to offer care at the home of patients when people cannot attend the clinic, although this is not easy to organize. And for instance, this is something we cannot organize in our center. What can we say about the management of nutrition? It's a very important aspect of the management of ALS. It is clear that weight loss is a very strong independent predictor of survival. Weight loss starts before the onset of swallowing problems, and even at diagnosis, the percent weight loss is an important negative predictive factor. Patients with weight loss more than 10% of their weight clearly do worse than patients that have no weight loss. It is known that when you put a gastrostomy in place and with enteral feeding, that you can prevent further weight loss. And so therefore it is easy to accept that this intervention would bring a benefit to the patients. But when you look at the survival curves, it is certainly not the case that by putting a gastrostomy and giving patients enteral feeding, even high caloric feeding, that you can completely wipe out the negative prognostic factor of the weight loss. There are no good RCTs that show that gastrostomy placement prolongs the survival, but of course it is the experience of many that it does in some patients. But probably it's important, if you do it, to do it early enough before patients are malnourished. For the recommendations, we first have a set of general recommendations. It's important to identify the causes of the weight loss and treat them if possible. For instance, by changing food composition and consistency, the meal frequency, by adding extra food supplements, make sure that patients with upper limb weakness, there's someone to help them to eat, and so on. But at a certain moment in time, when weight loss is progressive, the placement of a gastrostomy should be considered. It's important to discuss this at an early stage. And it's also important to discuss the benefits of an early placement and the possible risk and maybe also lack of efficacy of a late gastrostomy placement. The most important risk of a late gastrostomy placement is the respiratory insufficiency, which can worsen after gastrostomy placement. And therefore, in order to prevent early deaths after gastrostomy placement, it's important to identify if respiratory insufficiency is present, and then first introduce non-invasive ventilation, and even to perform the procedure while patients are on an IV. The management of respiratory symptoms is also very important. Respiratory failure is the most important cause of death of patients with ALS. And within the respiratory management, there are several symptoms. There is weak cough and thick mucus, and then the respiratory failure. For weak cough, we can offer different interventions, cough augmentation techniques such as manual assisted cough. Air stacking can be taught to the patients, and also the use of a cough assist device can be tried. But for none of these interventions, there are good RCTs. So we only make weak recommendations in favor of these interventions. But it's clear that it's important in order to try to prevent respiratory infections. thick mucus in the back of the throat is a common problem in patients with bulbar dysfunction and is a very therapy-resistant symptom, which can be very disabling to patients. It's important to look at the medications they take, because sometimes when the secretions are more thick due to, for instance, anticholinergics, this can aggravate this symptom. You can try treatments with humidifications, beta blockers, mucolytics, but in my opinion, they most commonly don't really help the patient. So it's a very difficult problem and very hard to treat. The respiratory failure, which is of course very important to detect in a timely manner and to discuss with the patients whether they are open to start a treatment with non-invasive ventilation. The first trial dates back to 2006 and clearly showed that in patients with respiratory failure, non-invasive ventilation could prolong the survival. This was quite a small study, and also the intervention was offered quite late, as you can tell from the control group in red, where almost half of the patients that only received standard of care at that moment in time without NIV died very quickly. But ever since, there have been numerous observational studies that have confirmed this effect. This is, for instance, the overall survival curves from our data sets, where we compared patients that had either symptoms or signs of respiratory failure and that were started on NIV or not on NIV. It's a propensity score matched analysis. And there seems to be a clear life-prolonging effect of non-invasive ventilation. And importantly, it also clearly improves the quality of life. The dyspnea, which can be very distressing, can be treated with non-invasive ventilation. Many centers use different methods to detect respiratory insufficiency, and therefore we kept the recommendation quite broad. We said NIV should be offered to all patients with ALS with either symptoms or signs or laboratory investigations supportive of respiratory insufficiency. And this means that you can use the techniques you are used to, whether it's FVC or SVC or nocturnal oximetry or nocturnal capnography, to take the decision or to guide the decision whether to start NIV or not. It's important to note that it's the initial study suggested that patients with bulbar dysfunction did not or less benefit from non-invasive ventilation, but more recent data suggests that even those patients can have a clear benefit from NIV. So it's important to allow the use of NIV independently of bulbar function. And this is probably an intervention that has a very large effect and which is still underused. For instance, in our center, we ventilate maybe only 30% of patients, and it's unclear why it's so difficult to obtain a higher number. Of course, there's some patients that don't want the intervention or do not tolerate the intervention, but still, I think we can do better for patients. The management of other symptoms, you remember it's a long list of disabling symptoms where we can often try to offer treatments. For most of these symptoms, there are no good RCTs, or at least not in people with ALS. A general principle for many of these symptomatic treatments is to take into account other comorbidities, because oftentimes you can treat two disabling symptoms with one therapy, and that's of course a gain. Sodium blockers are commonly used, and quinine sulfate as well. It's important not to go too high because of the risk of dysrhythmia. And so try to look at comorbidities. For instance, if there's also spasticity, you can consider baclofen or gabapentin. And this message will come back over and over in the symptomatic therapies. For spasticity, there are non-pharmacological interventions possible. The pharmacological interventions include cannabinoids. There is one, RCT, baclofen, tizanidine, or gabapentin. And when the spasticity is very focal, you can also consider botulinum toxin if it is reimbursed in your country. Emotional lability is a symptom that often occurs in patients with bulbar dysfunction. And there, it's the same message. When there are comorbidities, this can guide you in choosing a certain therapy. Most commonly used medicines are selective serotonin reuptake inhibitors, tricyclic antidepressants, or DMQ, which is dextromethorphan, hydrobromide, and quinidine sulfate. But when, for instance, patients have also sialorrhea, you could try tricyclic antidepressants. When they have clear anxiety problems, an SSRI would be better. DMQ may also improve bulbar function in some patients, so that can also help in taking the decision which compound to start first. Sialorrhea is a very important symptom also to treat when you consider starting patients on non-invasive ventilation. It's important to try to treat it beforehand. And again, other comorbidities can help you take the decision. For instance, if there is clear depression, that is tricyclic antidepressant could be used. It's also important to discuss with the patients that some drinks, such as fruit juices or milk, can stimulate salivation. Suction devices are a bit controversial, as they can be helpful in the short term, but as they can irritate the back of the throat, they can also stimulate saliva production. Anticholinergics are commonly used. DMQ can have a small effect on sialorrhea. And when pharmacotherapy is not working properly, consider botulinum toxin. It's important that this is done by a specialist person with experience. Surgical removal of salivatory glands is not recommended. Another topic we like to discuss with patients, but with a lot of uncertainty, is the prevention of deep vein thrombosis. The incidence of DVT or PE, pulmonary embolism, is not so low in ALS. It's reported to be 3 to 11%, the incidence, the yearly incidence. And it's clear that if patients develop severe leg weakness, that their risk is higher. It's up to 35%. In contrast, in the general population, the risk is very much lower, 0.1%. And about 25% of people that develop a DVT will later on have a PE, which can be life-threatening. And some of the patients that die in their sleep or die quite suddenly, most likely will die from a pulmonary embolus. But what can we do about it? There are no studies that show that primary prevention with anticoagulants is helpful. And of course, you can use low molecular heparins, but that's invasive. You have the subcutaneous administration, and the oral anticoagulants have not been studied in detail. So it's a field where we don't really know what to do. As a recommendation, we ended with a strong recommendation that it's important to discuss with the patients that they can have an increased risk of DVT, and that there is insufficient evidence to support the use of anticoagulants. Non-pharmacological approaches can always be offered, like passive physiotherapy, limb elevation, compressive stocking, and lymphatic drainage massage. So these interventions are obvious, but the main question remains, should we treat them with anticoagulants in a primary preventive setting or not? And we don't have the answer to that question. Finally, a few words about the end-of-life care, which is also a very important aspect of the multidisciplinary care of patients. It is an incurable disease, so we should have discussions with the patients about their preferences early on. This is a slide with data from the Netherlands, where both euthanasia and palliative sedation are legal. It's, I guess, very similar to the situation in Belgium, where more than 20% ultimately choose to undergo euthanasia, and an additional 15% die with palliative sedation. This is often chosen in a very late stage of the disease when patients feel that the respiratory insufficiency is increasing. But I think the lower the numbers here in the lower row are even more important. Only 24% of patients receive palliative care, where this should be offered to all patients, and only 20% had an advance directive. So I think this is a common problem that it's not discussed early on. And of course, it's important to try to prevent unnecessary hospital admissions. Many patients want to die at home, and it's important, I think, to try to do everything you can to let that happen in a peaceful manner. And of course, offering palliative care at home and having advanced directives are very important aspects to make this happen. This is just a figure also about the use of euthanasia for ALS in the Netherlands. This is in the y-axis the percent of people that die from euthanasia. And in red, for instance, you see the general cancer population. Over the years, this has increased a little bit, but all in all, it's only 6% of cancer patients that finally choose to undergo euthanasia, whereas in the ALS population, this is much higher. Of course, this illustrates what a serious disease ALS is, and that it has a very high impact on the quality of life of patients. With that, I'm coming to the conclusions. The guideline paper is out. We are very happy about this. It's freely available, so you can check it out. The update was urgently needed because of all of the changes in the field. MDT care remains the cornerstone and will remain the cornerstone of the management of ALS as long as we don't have cures for the disease. One new therapy is a game changer for the field, but it's only for SOT1 ALS, which is only 1 to 2% of all patients. Many new therapies are under development, and it's also important to stress that for many of the topics we discussed today, there is no good quality evidence. We need much more clinical research into the effectiveness of interventions for the management of ALS. And with that, I would like to thank all members of the guideline panel, as you can read there, the EAN, the Cochrane response, also the ERN, EURO-NMD, NCALS, UPALS, and the ALS Liga Belgium for all their support. Thank you.
So thank you, Philip. Very nice presentation. I think that presentation and the paper will help many of our colleagues manage their cases. And unlike what happens in many webinars, we have questions already for you. And both are about treatment. One from Dipti Bhaskar is how long Riluzole treatment can be offered to the patient.
How long?
Exactly.
Yeah. So we say lifelong because there is good evidence as well that it is still active later in the disease. I know that in some countries the reimbursement criteria request that, for instance, the pulmonary function is above 60%. But that was based, of course, on the inclusion criteria of the original trial. And with disease progression, this goes down. So I think from an evidence-based point of view, it is lifelong. If they tolerate it well, there is no clear reason or no clear evidence that can help us to guide when to stop the treatment.
Very good. The other one is about edaveron. So when is edaveron therapy indicated in ALS? And what is the usual dose recommended and for how long?
So in the guideline, we make a recommendation not to use edaravone. This, maybe it's also important to know that the timing of the guideline. So at the time we reviewed the literature, the phase 3 trial with oral edaravone in Europe was still ongoing, so we didn't have the results. And so we made a temporary recommendation not to use edaravone, awaiting the results of this phase 3 study. In the meantime, these results have been announced. They are not yet published, so they're not out. But we know that the phase 3 study was negative, so there was no effect on survival or disease progression or whatsoever. So I think we don't have a lot of evidence in support. I know the original study using IV edaravone, the first one was negative, but suggested that patients with a more steady disease progression could benefit from the treatment. And there was another study, not a very large study, that showed an effect of about 2 points on the ALS-FRS-R in 6 months. This gave rise to the approval of edaravone by FDA, but EMA did not do so. So in Europe, I think we have no regulatory framework to treat patients with edaravone.
Very good. So another question is from Sofia Nagy. We have tofersen treated patients complaining of burning paresthesias on the thigh quite often. Do you have any recommendation about this?
Is it the days after the administration? We have some patients that report a heavy feeling in the legs, some kind of fatigability, which typically occurs the day or 2 days after the administration and then goes away after another day or 2 days. This is probably a side effect of the treatment, but seems to be benign and self-limiting. Real paresthesias we don't commonly see. And of course, if you see severe sensory symptoms, certainly in the early phases of the treatment that were not there before, it's important to rule out that there is a myelitis, I think. But if it's a recurrent symptom, I haven't seen it that way.
So, hi, I was the one asking the question. And the thing is that they feel this pain all month long and they don't really respond to pregabalin or something like that. We tried these neuropathic medications already, and they don't really ease for that, even to larger doses, but they complain of sedation then when we give larger doses. And also, it's like 40% of our patients that do complain of this paresthesia, and only in the thighs, not in the distal limbs.
Yeah, I haven't heard it before, and I think we have now 22 or 23 patients on tofersen, and I've never encountered it. Yeah, so I think it's important, the real world evidence of the effectiveness of the therapy, but also the tolerability and side effects will become more clear with the use. So I think it's important to report and yeah, talk about it.
Thank you very much for the answer.
Thank you, Sophia, and do report it. It's important. The next question is about selection of patients to test for SOD1 in offer to have the possibility of offering tofersen. What do you have to say about it?
So the guideline was not about the diagnosis, so we don't include statements about that, but it's clear, well, maybe first we offer genetic testing to all patients already for more than a decade. Now with the therapy available, I think more and more sites offer genetic testing, because it's not only nice to know, but there's also a consequence, there's a therapy. It's improving, I think, how often it's offered to patients, but I think there are still very large differences across sites and across centers. There are initiatives by different patients organizations, including UPulse, to come up with some recommendations for it. But yeah, we have seen it with other neuromuscular disorders where there was no therapy before. We did not test that often. Once the therapy becomes available, I think the testing will follow automatically.
Excellent. So our audience is thinking about other questions, and I'm going to challenge you a bit. So you said that survival, fortunately, becomes not a very good endpoint now that people are surviving longer, and depending on the drug that you're testing, but it may not be a very variable amount to measure. And you also commented between the improvement of biomarkers that can precede the improvement of clinics for many months. And so my question is, considering these limitations that in part are a success, in part are effect of life, that some biomarkers may have a better responsiveness to treatments than the clinic condition. And we've seen several trials that you showed that the functional scales were not very optimistic, unlike the biomarkers. So what kind of adaptations do you think future clinical trials need to demonstrate both clinical benefit on one side and improved survival on the other?
Yeah, so that's a difficult question. Maybe first, I don't think that survival is not a good endpoint. I still think it's a very hard and reliable endpoint, but the study should be long enough. 12 months is a bit short, probably you need longer. And I think there's a trend towards more event-based analysis, where you run the trial as long as you need in order to have enough events to have the statistical power to come to a definitive conclusion. But shorter trials, it's difficult to use survival. And I think in early phase clinical trials, phase 1, phase 2, biomarkers are absolutely very important. I think it will become more and more important, and they will help us to take the decision which drug should go to phase 3. I think many trials, many phase 3 trials, maybe the decision was taken a little bit prematurely. But of course, for regulators, showing a clinical response will remain very important. The ALS-FRSR has limitations, but if the effect is large enough, I think you can pick it up using ALS-FRSR. But also there, I think the study should be long enough. 6 months is probably too short. You can most likely pick up reliably a symptomatic effect. But if you really want to pick up slowing of disease progression, I think 6 months is way too short.
Good, thank you. There is another question about how much tofersen extends life expectancy.
That's also a good question, and something we will not easily know. Maybe there will become data available about the very aggressive forms of the disease. In the US, the A4V mutation, we don't see that commonly in Europe. Because in Europe, we have more patients with a slower disease progression, and now on tofersen, they tend to stay alive. And so the control group was only 6 months, you remember? after 6 months, these patients are also put on tofersen. So we will not in the near future have a clear evidence on what exactly is the survival benefit in the slower progressing, typically in Europe occurring mutations. For the fast progressing, probably there will become more data available, hopefully in the near future.
That leads to a question that I had in my pocket regarding the long-term data collection through registries. And I was wondering if you have already any evidence collected that way to help answer questions like this, or if you're planning to do anything in that kind of data collection mode.
I think many centers already have data, and some have reported their data already. There's also a European initiative within Precision ALS to collect data from SOT1 patients on tofersen. And so it will be a matter of time before we know more, but it's clear that it can decelerate or even halt disease progression in patients, and in some patients also improve. And this is, of course, something we have never seen before, and is very encouraging.
Very good. There is no more questions for the moment. I think that people have extensively abused of your expertise, and I think they did it very well. And we hope to have you with us in a very near future, discussing these issues and others. And I thank you again for your marvelous webinar. And I would remind everyone that these webinars are recorded and you can review on demand afterwards on our website. And if you don't mind, we would appreciate your feedback about the webinar. On the chat, I left the link for you to click and give us some feedback about the webinar. It will be much appreciated. Thank you very much, Philip, and we'll meet soon, I'm sure.
My pleasure. Thank you very much.
Thank you. Thank you, everybody.